So normally we start with a CPAP of 5 to 6 centimeters. So in a baby with respiratory distress who is mildly distressed, you can use closer to 5. But if there is significant recession, we can go straight to 6 centimeter of water. And as I mentioned, ensure the humidifier is on. There are three possibilities from this stage. The baby stays stable on CPAP, the respiratory distress improves, blood gas is improving, and the oxygen stays below 0.3. In this case, just continue the CPAP and wean as possible according to what your unit practices. Some of us wean to high flow, some of us wean the CPAP pressure to 4 and then take off CPAP. If the baby has significant retractions, respiratory acidosis on the gas with or without an abnormal chest X-ray, so the X-ray may not be too abnormal in the beginning and it can take time to evolve, so the X-ray picture is not going to really guide you on this. We sometimes wait for the X-ray unless you have a worry of pneumothorax till you put the lines in. And the oxygen requirement is more than 0.3 or approaching 0.3, then you go for surfactant therapy. If the baby has increasing distress, the PCO2 is high on gas but the FiO2 is below 0.3 and the effort is good, we could increase CPAP to 6 to 7 centimeter maximum. We avoid going to very high pressures on CPAP without surfactant in RDS. So remember that if it's a later stage of lung disease, your post the first surfactant deficiency stage in the first 3-4 days, it's a different scenario. But in the first 2-3 days when the disease is evolving, when surfactant deficiency is a primary cause, you want to replace the surfactant as far as you can. In resource limited settings, you have to decide how you approach it, because if surfactant is a valuable resource and you want to limit it to only the most essential cases, you could consider NIPPV, but that increases the risk of pneumothorax. And we recently did an audit in our unit and we have decided not to use NIPPV. Once you reach a CPAP of 6 to 7 and the baby is not maintaining, we go for surfactant first and then we go for NIPPV. So obviously the stiffer the lung, the higher the pressure you use, the higher the risk of the tissue breaking and air leaks happening. So that is a basic reason this happens.